okay, so okay, so feeding. Okay, hot topic. Hot topics in neonatology about feeding. I will talk about feeding on CPAP, but I did put into my talk a little bit emphasis on feeding in general. Oops. Okay, so here we go. We cannot talk about feeding without reminding ourselves that we do have growth charts, and the growth chart help us in two ways. One is to decide whether our baby is appropriate for gestational age or a small for gestational age baby. So these are graphs that help us. Here down, we have the gestational age and the weight. And if the weight will be under the third percentile, then the baby will be SGA baby. And if the baby is, this is 42 weeks here, if the baby is less than 37 weeks, it's going to be a preterm baby. So in order to establish, in general, approach to feeding, we have to know whether the baby is an AGA baby and if it's a term or a preterm baby. If it's an SGA baby, also needs a specific approach from our thinking in the daily work. The second thing that the growth chart help us, that if the baby is born in the 30 weeks gestational age, this is actually an intrauterine growth. And when the baby is born, we want to be as close as possible to this normal growth, which is very, very difficult to achieve when the baby is not receiving all the necessary calories and nutrients through the placenta. When we have to feed the baby, how can we do everything possible that the baby is actually progressing in his growth? And this growth is necessary to improve the immune system and to improve also not only the physical growth, but also the maturation of the tissues in our body. So the caloric intake and the fluid intake are two separate things, but they always are discussed together. You can have a fluid intake like water and no caloric intake, and you can have enough caloric intake and enough fluid intake. And this is important. This intake is not only fluids, but it's also protein, glucose, fat, trace elements, vitamins. All these are in the intake that we have, and of course, fluids. When you have enteral feeding, then it is a balanced intake. Usually, breast milk contains everything in the right amount, of course, contains everything that the baby would need. So when we assess the need of a baby, we should have a protocol ready in our MBU, but we have to assess the maturity. A baby who is less than 34 weeks gestational age, the sucking is inefficient. So putting a baby on the breast for direct feeding, and the baby is less than 34 weeks, will not probably give enough intake for the baby, as the sucking is ineffective. The baby has to be well, has to be assessed. If the baby is sick, is not well, just a minute, I have to move this. You have to assess the well-being of the baby to decide about enteral feeding or IV fluid. A sick baby cannot have oral intake. Clinical status means that is the baby breathing fast, is any respiratory distress, What is the state of conscious, and more other clinical issues. Again, ask yourself, is the baby able to feed enterally? Is the baby needing IV fluids? You decide if the NG tube is needed, as you have in your mind. The intake has to be intake, either by gastrointestinal, enteral, or either by IV. All babies on CPAP need an NG tube. This is clear. You have to calculate the appropriate amount every day. And of course, every assessment when you go to the baby on your regular checkup, you want to make sure that what you decided in the morning as the amount needed, the baby could really have this intake. So calculating and making sure that you are able to give this amount. You have to have very clear policy when to give formula. And this is a big issue, as we all are for breast milk and breastfeeding. But sometimes when caloric needs are very important, you have to consider artificial formula almost as a medication in order to make sure that the baby is growing and getting healthier. You have to monitor and document your feeding, that's clear, and increase the feeding as per protocol. Okay, that's fine. So NG tube is indicated in all babies who are preterm unable to suck under 34 weeks. Ineffective cup feeding, volumes not taken in, and the baby cannot swallow in the appropriate amounts. The baby is in respiratory distress, neurologic impairment, and not always, and you have to consider that sometimes some feeding could be given orally and complemented by supplements through either cup feeding or NG, but the daily intake should be achieved. So you need a positive balance in order to grow. If you don't have intake, you are going to lose weight and be unable to fight your disease. Sick babies have more caloric needs, so even more so in the sick babies, they need the appropriate amount of intakes. The balanced intake, as I said, caloric, fat, protein, glucose, all this is better achieved when we give oral or enteral feeding, and less balanced when we give IV in your setup when proteins and fat are not supplied via IV fluids. So when you use only glucose, when you use only glucose, this is missing your proteins and all the other ingredients. If you use only saline, then you have electrolytes, but you don't have enough calories. Preterm and small for gestational age babies, as I said in the graphs before, have absolutely no reserves. So they can become very fast hypoglycemic and inappropriately fed. So enteral feeding should be initiated at the first day of life, and you have to ask yourself very clearly, if this is not happening in the first day of life, why is the reason that you didn't start enteral feeding? You should start a minimum of trophic feeding, which is 2 milliliters on, even in the very small babies, to initiate a proper function of the intestinal tract, and complemented with IV fluids. In the preterm, very small babies, you need IV fluid as to start with in order to keep glucose levels appropriate and not to get hypoglycemic, and slowly build up the enteral feeding as soon as the baby can tolerate. So contraindications for feeding are very few. If the baby has uncontrolled severe hypoxia, and you might be in danger of having necrotizing enterocolitis, you should not feed the baby and wait until your oxygen level becomes normal. If the perfusion is very low, again, it's very you cannot enterally feed the baby, because the gastrointestinal system also can suffer from hypoperfusion, and the baby will not tolerate the feeds well. If you have an increased abdominal circumference and that compromises your ventilation or the need for respiratory support, then you might want to stop feeding and give a rest for the baby until the baby has better respiration and you can start feeding. And of course, if you have a congenital anomaly of intestinal obstruction, then you don't feed the baby. So actually, only 4 reasons that you will not want to feed a baby, okay? Or it's severe hypoxia, very low perfusion, increased abdominal circumference, or intestinal obstruction. There are no contraindication for a baby on CPAP or umbilical artery line or umbilical venous line. All these babies should be fed. In asphyxia, usually in the first 24 hours, probably because you might be worried about the oxygen level, again, perfusion of the intestinal system, but after 24 or 36 hours, these babies can be fed. So inserting the NG tube, good technical approach, and be sure that you know how to insert and how to secure your NG tube in order to make sure that the food is getting into the stomach. Gravity feeding is very much encouraged, as mom can keep the baby in the hands and keep the syringe open, and the milk is put into the syringe and it's actually going down by gravity, which is very natural way of getting in the food. Sometimes you might have problems. A baby can move the NG tube from its place, but with careful securing, this is a very good method, and actually the advised method to feed babies in the NG tube. Every day, as we see, we'll see in a minute on your own charts, we evaluate whether feeding is going well. And you examine the abdomen, you evaluate if there is any distension. If you have air in the abdomen, you remove it with the NG tube in place. You check for the residua, and you want to see the color and the amount. If there is a small amount, if the color is milk or it's bile or undigested food, it's all important to evaluate the magnitude of the problem. Did the baby give stool? Again, babies who are very small might have difficulty in having stool. And if this causes abdominal distension, then this can give residua in the stomach, and you cannot go ahead with proper amounts of feeding as calculated by your daily calculations. So if the baby also, as I said, bowel sounds, you can auscultate to see if there is good bowel sounds are present. So if this is a chart that I had looked at it, and again, let's see, this is a 3-kilo baby, day 1. So probably a term baby. I don't have here the gestational age, but I presume with this weight, this is a term baby. And we can see that this baby had a respiratory score 5 and had a very low saturation. So the baby was not given food. It says here no feeding. Okay, that's good. Probably because of the baby was still not saturating properly. The glucose level was checked every 4 hours. So the baby did keep the normal level of glucose. And I think I don't see here the lower part of this notes. But this baby was given IV fluids. Just a minute. Why can't we see here? You can see it here down here, that you can see that actually the baby was given IV fluids So this is the chart on the day when the baby was not saturating well. Decision was made not to feed the baby, but glucose IV was given with a calculated rate. To compare, this is another baby, which actually this is the first day of life, small baby. So either it's a term SGA baby or a preterm baby, was in the MBU because of respiratory problems, but the glucose level was checked on admission and the baby was not fed during between 6 and 4 o'clock in the morning. And this is something that, and it was not given IV fluids either. So this is something that was probably putting the baby at risk for developing hypoglycemia and dehydration. We assess the adequacy of feeding by checking the adequate urine passage. It's a good thing if you look at the part of the GI and feeding assessment part of our chart, you can see that we have here passed urine, and the issue of yes or no urine is very helpful in somehow having an idea about the intake of the baby. So no urine means that the baby is on the dry side and probably needs more fluid intake. So we do need to look at the urine passage and to assess whether the baby gave urine and check it in the chart. We expect at the initial weight loss, even if we give proper intake at the first day, but we are okay with 10 to 50% of weight loss, and then we are hoping for a 20 gram per kg weight gain per day, which would be a good situation in which this baby will probably keep the centiles for the age.
Agi, can you go back to presentation mode?
Yes, sorry. So this is again the baby which I showed before. The baby was not given food and was not given IV for a significant number of hours, and this is something that we need to think about. How can we make sure that this is not happening, either by putting an NG tube in and giving artificial food, if this is what is needed because it's a preterm baby and the mom is not yet able to provide necessary amounts. But anyway, this is something that we want to see not happening. Positioning is very important regarding the feeding, and although here it's again the Hudson prawns, but just an example to show you that the neck has to be elevated, the chin has to be elevated and put in some kind of support in order to make sure that in the baby, not only the air is entering properly, but also the NG tube goes in and easy to see that everything is working well. Prone position is the best for feeding, but sometimes this is not possible with all the respiratory support that these babies might need. I have here a short video to show you how to prepare the little nests for positioning the babies while feeding. It's very nice, homemade video from our department. So take a look about how do we prepare the nest.
I'll show you how to prepare a nest for a premature infant baby. First, take a clean blanket and place it on a straight surface. Next, take 2 cloth diapers, flannel diapers that are the same size, and align them together. Then fold them into the shape of a triangle and roll over to form a tube shape.
Okay.
Then take an extra cloth diaper and place it on top and roll it over the rolled diapers. Roll it halfway and then fold over the edges to form a U shape, which will form our nest. Then fold over the edges and tuck them in. If your baby is under 28 weeks or under 1 kilo, you can form an extra roll for the head of the baby. We take a soft tetra diaper and place it on all cloths for the side of the head of the baby.
This is the side. This is the leg.
To complete the next nest, take another diaper, cloth diaper, and fold it in half and place it on the nest. And another cloth diaper to protect from secretions. We will now show.
Okay, so you don't have to have diapers. You can have any cloth can do the same. It's very helpful in positioning babies, also for good feeding and for good CPAP support. So the weight gain should be 20 grams per kilo per day, and you might want to weigh the baby every day. You have to think about whether you want to weigh the baby every day or maybe every other day, because it's very stressful for mom. If the intake is appropriate and you documented the intake properly, it's not really very, it's very stressful for mom if this 20 gram did not happen. So it's sometimes easier or better to not to do it every day. But of course, remember that you monitor the intake and you are sure that the daily fluid intake is done. Now, if indications that there is any feeding intolerance, we check the abdominal distension each time and you remove the air from the NG tube before feeding. So each time before you feed, you remove the air and then you put in the food. This is very important for the babies on CPAP. Increase, you check the abdominal tenderness, and you will have a significant amount of residua in the stomach if there is feeding intolerance. You can see the baby looking sick, having apneas, and reduced bowel sounds. This is signs that maybe the baby is developing necrotizing enterocolitis, and you will want to stop or reevaluate whether you can continue raising the amount of food. So when do you put the baby on nothing per os? Only if the baby is if the baby looks sick, if there is a big amount of residua, more than 50%, then you first might want to skip 1 or 2 feeds before you stop completely. You might want, if the amount is between 25 to 50% of the amount given, you might want to reduce the amount in the next feeding, adding to the calculation the amount that was in the stomach at the beginning of the feeding. And if the residua is less than 25%, then you just continue giving the full amount and hoping for the good results for the next feeding. If the baby looks sick, you might want to withhold the feeding for 24 and 48 hours. Checking, so each day when you do the rounds, you will have to reassess whether feeding can be increased, is tolerated well, based on all these signs that I have just emphasized for you. So babies on the CPAP should have NG tube in place. You have to remove the air every 2 hours before the feeds. You do not throw the residua that you receive in the NG tube if it's a small amount and good color. And you continue the feeding. Sometimes you might need to feed slower, not in bolus feeding. And it means that you will give the feeding through the NG tube in small amounts during a longer than the half an hour feeding time. You can give it as a 1 hour or 2 hour continuous feeding. And of course, during the CPAP, even the baby is having this intensive care approach, you encourage the mom to express breast milk that will be given to the baby via any way possible. Sometimes when the mom sees the baby on the CPAP, she might be discouraged. She might not believe that the baby is going to make it. So remember to encourage and help her, helping you, treating the baby with appropriate amount of expressed breast milk. Kangaroo mother care can be done on babies on CPAP. So here is a picture of a baby. Here is a baby in a CPAP with CPAP on mom. You have to remember a few things about this thing. The baby has to be stable, like good saturation. You have to have an experienced and confident nurse available to support mom in positioning and making sure that the airway is clean and good, so the baby can continue receiving the CPAP with no problem. You have good monitoring, so the saturation monitor is well on the hand of the baby. You have to prepare before, like a good chair, enough tubes that it's not pulling anything out from the machine, and the cloth to cover the baby. The face should be visible so the mom can see the baby. And you should try this in the unit by practicing with a doll. Put the baby on a CPAP and practice putting the baby on kangaroo mother care. It's a very, very good method on building confidence in mom and actually increasing breast milk and all the good positive effects of the kangaroo mother care, even if the baby is on CPAP. So remember, kangaroo mother care can be done on CPAP. Okay, why it's not working? Hello?
You are there, we hear you.
Yeah, but it's the slide, okay. Okay, sorry. Okay, so in summary, okay, we just said that feeding is important in healing, encourage breastfeeding and milk expression at all times. Sometimes formula is needed as a medication. Each day, clean orders for feeding. Babies on CPAP can be and have to be fed. No intake is very bad for the babies, and CPAP is not a contraindication for feeding. So this would be the main point that I would like you to have regarding CPAP and feeding. I think I had one more example here, but I think I will stop and more. Yes, this is one more, just one more example of very nice charting that this baby was admitted to the MBU, given IV fluid at the beginning as he needed a lot of oxygen. And when the feeding, an NG tube was inserted and feeding was started, then is 6 ml, then the IV fluid was still continued as the feeding was not enough. And I just wanted to emphasize that here you would need some adjustment to reduce the amount of IV fluid if there is intake already enterally. So the total intake will be not too much and above the calculated amount needed for a baby. So this is what you would want to see in a baby having IV fluid started on NG feeding and then slowly weaned from the IV, slowly going on the full enteral feeding. So this is what I had to say at this point. Thank you very much. And I'm open for questions.
Aggie, thank you. There is already a few questions from Alberta.
Okay, so read them loud. Where is it?
Do you see them? Well, I start with the last one, okay, because it's the easiest to answer. When a baby continuously vomits greenish or meconium fluid, is it a contraindication to feeding?
Mm-hmm. Okay, remember that this alone is not enough for decision making. So you want to have, is a preterm baby or a term baby? Is the baby look sick or is the baby looking vigorous and hungry? Is the amount more than 50% of the previous feeding? And if there is a small amount and the baby is did pass stool, again, another point, then you will want maybe to skip one feeding and follow up what is in the NG tube. Vomiting means that probably either the NG tube was not in place or really it was a very big amount of content in the stomach. So this would need a careful clinical consideration. You would stop probably if the baby is vomiting, then you might want to stop. Remember, if the color is due to meconium fluid at the admission, because the meconium stained amniotic fluid is in the stomach, this is not a reason not to feed a baby. Just clean the stomach, wash it up, and then start feeding.
I think you're right that if in the beginning the color of the vomit is greenish, it may be due to meconium. But if after several days you have green vomits, so then it's an issue and you may want to stop feeding and see if the baby does not have an intestinal obstruction. Now, the other question that is also interesting, please, do we increase the total fluid requirement for babies being nursed under radiant warmer due to increased risk of fluid loss?
Okay, the answer is yes. Remember that the babies are in the round cannula, they do have humidifying, so this is good. But sometimes if you are on an overhead heater, then you might need about 20 ml per kg per day. added to the total amount of fluid taken. If it's a closed incubator, which you don't have in your setup, as much as I know, in the ventilation, in the babies who are on CPAP, you are on the open overhead, then in a closed incubator, you might need a little bit less. But in a radiant heater, yes, 20 ml per kg per day. More question on the chat?
You answered already the question about if vomiting is a contraindication to feeding. And vomiting, I think, is a very tricky question, because sometimes it's kind of the overflow of fluid you know, it just that the baby is not really vomiting, it's just some overfeeding, or it just doesn't feel very well. And as Agi said, it's very important to see how the baby is, to see if the baby feels well, to see his abdomen. And each case by case, there's no right answer to this question, I think.
I think that what we often saw in the charts, you might want to think about feeding a little bit more more seriously, as it at the beginning. It can be cause of severe hypoglycemia, especially in the SGA babies, and you might not see anything, and the baby can get some damage from hypoglycemia. And in preterm small babies, you absolutely need the calories. So I know that in your setup, the issue of if you don't have enough mom's breast milk, then artificial formula is an issue. This has been discussed many times in many setups, at least for the first 24-48 hours until mom has enough breast milk. These artificial formulas are better than plain IV fluids glucose given to these small babies, which is actually very low in caloric and puts the baby in catabolic state, catabolism, which is very bad for many organs in the preterm babies. So in some places that I know, artificial formula has been under medical subscription only. It's like the concept of a drug. So not to have it free, that any mom can have anytime artificial feeding because she's tired and this is not appropriate use for artificial feeding, but artificial feeding would be absolutely necessary when the caloric intake is low and it has to be supplied. So I am not sure what is today the setup in your units. I know the phobia from artificial food, but it's also has to be considered in these very small sick babies and preterm babies. We are keeping alive these small babies and they need calories, and IV is dangerous for sepsis, and you better feed them enterally with breast milk, and if breast milk is not available, then with artificial formulas for at least a bridging time of 24-48 hours. I would like to hear what is the situation today in the unit about artificial formula. Rita, Ashura?
Rita just left, but the Joyce is here and Ashura is here, and it would be interesting to hear how you're dealing with these issues. Ashura, are you there? Anybody want to comment from the group, because we don't hear anybody?
Okay, I guess it's late. The talks will be available online for everybody to re-discuss and send us questions by mail as you did in the previous lectures. And I'm sure those are important topics that you are discussing every day. So I think we are going to close at this point. And thanking you so much for your time. It's very late. And for the you're willing to participate and really thank you so much. Thank you, Professor Karplus, Eilon, Justin, Benil. I see so many. Yankele is here today. So thank you, everybody. Eilon, closing remarks from your side?
I think we dealt with two very important issues, and even three, because we started with sepsis, we continued with respiratory issues and weaning from CPAP, and feeding issues, which are, all of these issues are not easy to deal with in the clinical context. But Agi, thank you for your very nice talks, and I hope that they will help, and even, you know, even if not changing, just create a little bit of discussions in the units. And you're always welcome to send us questions and to ask your Dr. Rita and Ashura and Joyce and your doctors. They will be happy to answer these questions.
Okay, thank you so much.